Welcome to another EduMed video, and in this video we'll be talking more in the series of the ITU ward round and focusing specifically on F for fluids. We'll talk a little bit about renal function, how to assess volume status and how to manage patients with oligoanuria, and then touch upon renal replacement therapy. However, we're going to do a whole series on renal replacement therapy in detail so that you have a better understanding of this. Well, acute kidney injury is very common in patients in intensive care, and there are a variety of different ways in which you can monitor it. For the most part, patients who have a drop in their urine output or those with a worsening renal function, specifically their creatinine, usually are an indication for acute kidney injury. There are a variety of different categories of renal failure and renal impairment. However, for the most part, if you start to see the renal function going off, you need to do the same things anyway, and that is to do a renal screen. To do the renal screen, you need to really think about what the causes of the renal dysfunction could be. In a lot of patients in intensive care, it is pre-renal. It is patients who have a reduced flow into the kidneys, either through hypovolemia, possibly through septic shock with a vasodilatory shock, reducing the renal blood flow through, or it could be intrinsic to the kidneys itself. The kidneys are quite sensitive to circulating cytokines, and certainly in patients with cytokine storms or other septic conditions and non-septic conditions, you can get intrinsic renal dysfunction. This is something that really needs to be treated through treating the underlying condition. And finally, post-renal causes. This is rare in intensive care. However, certainly we do see some patients going into obstruction. This could be secondary to stones and also just secondary to ascending infection as well. Either way, we need to screen for all three of these different types of causes for acute kidney injury. So in terms of the investigations, it's fairly similar to what one would do on a medical ward. So you'd want to do an ultrasound of the kidneys, and this is really to detect whether there's any evidence of post-renal complications such as obstruction with hydronephrosis. A urine dipstick is really vital in these patients because actually it can indicate problems, and especially if you find nitrites, this could be an indication of some nitrite-forming bacteria causing a urinary tract infection. Blood is also really helpful. Of course, one has to take that with a pinch of salt if the patient has just had a catheter put in, but for the most part, if you do see blood there, do think about interstitial nephritides, which are not that uncommon in intensive care and can be precipitated by some drugs as well, especially the non-steroidal anti-inflammatories. Urine MCNS is really important, not just to look for bacteria or fungi that could be causing a urinary tract infection, but also sometimes you can see glomerular casts. However, you do need to specifically ask for this from the lab and take it to the lab, take the sample of urine to the lab straight away, because those casts can dissolve in stagnant urine. A bladder scan is something that's really important, even if they've got a catheter in, if you have a patient who's starting to develop oligoanuria. This is because sometimes the bladder can go into spasm, or alternatively the catheter itself can get blocked, especially if the urine has a lot of sediment in it. And by scanning the bladder you can see how much there is and give the catheter a flush, which may well unblock whatever was blocking it. Another thing that's often missed in intensive care but worth thinking about is measuring intra-abdominal pressures. This is done really simply by putting a urinary catheter into the bladder, clamping it for a short period of time, developing a column of water and literally just lifting up the catheter to see how high the column of water goes. As intra-abdominal pressures increase, you get increasing venous congestion and a reduction of venous return into the vena cava. As the organs become venously congested, they can cause interstitial dysfunction, and the kidneys are significantly affected by increased intra-abdominal pressures. If you don't think about it, it's something that can be missed. Usually, as the intra-abdominal pressures increase, then you get difficulties with ventilation as well, so that might be another clue. Reasons for increasing intra-abdominal pressure are usually relating to bowel, with the bowel becoming more distended, inflamed, or if it's ischemic. However, it can happen with quite significant ascites as well. One of the key things about intensive care is assessing a patient's fluid status. Now, if you just take their total body water, almost every patient in intensive care, certainly within the first couple of weeks, is fluid overloaded. This means that they've got an increase in total body water, and that usually manifests as being very edematous. Also in the lungs, they become quite edematous, and so patients usually have an increased oxygen requirement as well. This is very different to the intravascular volume, and when we're thinking about flow into the different organs, this is what we care about, is the intravascular volume. So when assessing a patient, we should always be thinking about what their intravascular volume is and whether they're euvolemic, hypovolemic or hypervolemic when purely looking at the intravascular volume. Total net body balance is always going to be positive, and that's why as patients improve from their critical unwellness, they should be offloaded, and often most patients do an autodiuresis as their renal function recovers and as they improve from their underlying infection or a serious illness that they were brought into intensive care for. In addition to patients' intravascular volume, two other things that are important to bear in mind are the intravascular oncotic pressure. By that, what I mean is what's their protein and their oncotic pressure within the blood vessels themselves. Often, in patients who are very unwell, they can become catabolic and also impair their albumin production, and as such, their albumin levels can drop quite significantly. As such, the fluid inside the blood vessels start to leak out down an oncotic gradient, as the tissues around the blood vessels often have more protein than inside the blood itself. Similarly, with severe infections or inflammatory states, you can get vascular endothelial disruption, i.e. the capillaries become leaky. That's a normal physiological response in inflammation to allow the white cells to extrude out of the capillaries and into the interstitium where they can fight disease. But the problem with this is that it'll also allow proteins and fluid to extrude out as well, and again increase the extravascular volume. In terms of diuresing patients, there's really two options. One is the pharmacological option, and that's diuretics, and the most commonly used one is furosemide, and the other option is renal replacement therapy. As I mentioned, as patients get better, they do start to autodiurese without us having to give anything, but this can take weeks or months to start happening, and often these patients need to be diuresed earlier than that to be able to wean them off mechanical ventilation and to improve their interstitial tissue function. Things to be aware of with furosemide is that it can cause hyponatremia, and actually quite significant hyponatremia. There are other diuretics that can be used that balance sodium extrusion more. However, for the most part, furosemide is our first line in most intensive cares. Be careful about the dose of furosemide and what other drugs you're giving the furosemide with, because it can cause quite significant ototoxicity, and it's not unheard of for patients to come out of intensive care with significant hearing impairment, and we think that might be a combination of high doses of furosemide, so more than 240 milligrams in 24 hours, associated with additional ototoxic agents such as vancomycin or gentamicin. Renal replacement therapy is sometimes used for patients with volume overload and is probably the most reliable method of getting rid of fluid if fluid overload is a significant issue. However, it does come with its own morbidity and potential mortality, so it should not be a decision taken lightly, and one that should be taken by a senior doctor such as a registrar or consultant. It's quite a nice segue to just think a little bit about what the indications for renal replacement therapy are, when to start it. And there are a variety of different reasons for starting it, but the four that you should generally keep in your mind are: One is an intractable acidosis. This is an acidosis that isn't improving with fluid therapy and in some cases bicarbonate therapy. If you are giving bicarbonate, it should be discussed with a senior doctor, as it can have its own issues and it may mask the underlying cause for the acidosis in the first place. Fluid overload is a really important issue as well, and for patients who have significant fluid overload, such as those patients who have renal failure and aren't on dialysis, who are getting increasing oxygen requirements, it could be a good way of actually offloading the patient. Intractable hyperkalemia is a very important reason, and never delay a patient who is persistently hyperkalemic with renal dysfunction from going on to renal replacement therapy. There have been cases of people having cardiac arrests whilst waiting to go on to renal replacement therapy. Using insulin and dextrose as boluses only temporizes matters. You need to get rid of that potassium, so either by using ion exchange resins or increasing urinary excretion of potassium through furosemide or renal replacement therapy are really the only ways to get rid of it, and that's got to be the key thing to try and do. And the final thing is uremia. This is a little bit more of a softer indication. There are no absolute values for starting renal replacement therapy, but for most people above 40 you'd need to start considering it. In terms of the uremia, the things to actually consider are whether the patients are becoming symptomatic, so becoming confused or developing a serositis such as a pericarditis or a pleuritis. Often, patients with chronic renal failure who are on dialysis may well be running ureas of 40, 50 or even 60 and not be symptomatic because they've got used to it, because urea is an osmotically active compound, and so by changing the amount of it quickly you can get large fluid shifts, which is usually why you get the symptoms of uremia. However, if it's happened slowly over months or years, patients often aren't symptomatic, and so there isn't that great rush to start renal replacement therapy acutely for those patients. The other things that we think about in intensive care are the clearance of some drugs, and certainly drugs such as aspirin, which is water soluble, can be very effectively removed from using renal replacement therapy. However, we'll go through all of that in a lot more detail when we talk about renal replacement therapy in those lectures. Another useful thing to think about is when to stop renal replacement therapy. So when you see the patients on the ward round who are on dialysis, it's worth thinking about what form of dialysis they're on, whether they're on continuous vena-vena hemodialysis, intermittent dialysis, or on filtration, because all of those things may slightly change the way in which you manage your patient. But if a patient is starting to pass urine, you need to ask yourself two questions. Firstly, is it an adequate quantity of urine? Are they producing roughly 0.5 ml per kilo of urine? And the other thing is whether they're providing a good quality of urine. You will find that some patients actually start to develop a polyuric phase to their acute kidney injury. However, they're not able to concentrate any of the parts of the urine, and therefore, even though they're producing lots of urine, they're not clearing potassium, they're not clearing urea, and they're not clearing creatinine, and therefore the patients are actually passing urine, but it's not a good enough quality for them to come off the renal replacement therapy. The only way to really know for certain is to actually give patients what so-called filter holidays. This is to stop the filter for a few hours or even for a day and just see what happens to the blood results. If the urea, creatinine continue to go up, if the potassium continues to go up, then you might have stopped prematurely, or the patient may need chronic hemodialysis, and that will be a discussion with the renal physicians. The common mistakes that are made when assessing for fluids is maintenance fluids. If patients are able to take fluids enterally, i.e. NG feeds or NG water, try and avoid giving those patients maintenance fluids with intravenous fluids as well. If you are giving intravenous fluids because the patient can't take anything enterally or you're not sure they're absorbing fluid, Generally between 0.5 and 1 ml per kilo is per hour is the rough amount of fluid that you should be giving these patients. Bear in mind that patients on intensive care often become very positive, and a lot of the intravenous fluid you give patients extravasate into the extravascular space. That's all fluid you're then going to have to take off later. So some people adopt the policy of not giving maintenance fluids and just giving boluses of fluid when needed, i.e. if the blood pressure starts to drop, if they become tachycardic, or if they start to develop a bit of a lactatemia. There's no right or wrong. There is certainly evidence to say that if you give patients too much fluid, it is bad for them and it increases both their morbidity and mortality. So less is probably better. Err on the side of caution, and don't be afraid to give boluses of fluid rather than continuous infusions. The other common mistake is missing causes of renal impairment. Make sure you do a full acute kidney injury screen for patients. It is not forgivable to miss a post-renal obstruction of a patient if they've got infection, because you can cause quite significant long-lasting renal damage. So make sure you do get the ultrasound. Make sure you do the urine dipstick to check whether the patient has an interstitial nephritis. Review the medications that a patient is on, and if there is anything nephrotoxic, do consider changing to something else if appropriate. And the final thing is much more subtle, which is to measure the intra-abdominal pressures. If they are high, think about how you can manage that. Drain off the ascites. Speak to the surgeons about doing a laparotomy and removing the dilated ischemic loops of bowel, for example. But do think about it if you do have patients who have continual deterioration in their renal function. So overall, the most important part of the ward round when thinking about fluids is thinking about the volume status, and we're talking about intravascular and extravascular volume status. Investigate any causes for renal failure, and if the patient does show signs of acute kidney injury, do not rest until you've ruled out all the significant things that could be causing it. Consider when to start and stop renal replacement therapy, but certainly talk to your seniors when thinking about this. Avoid those common mistakes that I went through on the previous slide, and probably the most important thing, which I would highly recommend every person to do, is always set a fluid balance. Even if that fluid balance ends up being neutral to plus 500, which is standard for most patients in their recovery phase, or setting a fluid balance of own if they're starting to autodiurese. That's fine, but keep an eye on it. What you do not want to do is to allow patients to become too positive. And there is always a tendency in intensive care, especially with all the drugs and things that we give them as well, for patients to become quite significantly positive in their total body balance. Neutral to plus 500 will account for most insensible losses, so effectively keep people at a steady state in terms of their fluids. If you want to diurese them, do driver diuresis, either using furosemide or renal replacement therapy. Aim to get the most negative that you can that's physiologically achievable. So aiming for -6 litres is probably not an appropriate thing. We sometimes do that, especially in patients with significant severe respiratory failure. However, for the most part, aiming for negative -500 to -1 litre, or even up -1 litre to -2 litres is probably the limit of what's acceptable for most patients and what they can cope with physiologically and hemodynamically.